Okay. Hey, Health TikTok Show. Miriam, put yourself on mute.
I got her.
Someone is echoing super bad. You're all going off stage. I don't have time for this. Okay, it was one of them. One of you has an audio problem. You have a few minutes to figure it out. Congratulations. Hello, Health Tech Talk Show. Loyal fans, we are a little late today because, as usual, we had a myriad of technical issues and are continuing to have those. So, but like I told our special guest for this afternoon, Dr. Stephen Patrick, who is a fancy person, like, people still love us. So listen, Lisa's in India. So we have our regular all-time favorite guest co-host, Leslie Kirk.
Very excited.
Yeah, we got stuff going on. Without Lisa telling us all of the policy details that we did all week, we do have another special guest who's going to explain some PBM things to us. She's also a regular contributor. I don't know what we're going to call her, but she'll be on in a bit. But yeah, it's been kind of a wild week. I'm going to try really hard not to make a lot of comments about lizard people, but it's clearly not going to work. It's not going to work.
You can't even help yourself.
I just want everybody to know lizard people are out there. Anyway, Melissa, what's going on?
Been a busy week, just doing the things as always. Sponsor. Give us your money so we don't have the technical difficulties. Spots are being taken up for health. I think I have 3 more as of right now. So if anybody's interested, please reach out before it's too late.
Yeah, it's going to be too late. We also, like everybody, because Lisa and I have to do our real jobs and speak a bunch. We're actually only having 2 shows at 5. So we only have room for 8 interviewees, which goes real fast over 2 shows. So yeah, call Melissa, not me. Like, don't call me because I'm just going to CC her in anyway. It's going to
you're just going to get looped into me anyway, guys. So
yeah, just call Melissa. She's the best. Anyway, Leslie, what's going on? What happened?
Nothing. Just in general in life. I am excited about today because we have 2 people who have no problems sharing their very large opinions on the internet. So I think that's going to be a fun time. I think
both of them do that often.
Like all the time. Yeah, it's going to be really fun.
I'm here for it.
Hold on. Okay, let's do
I just want to point out that we are now down to 2 spots or maybe 3. I don't know. I just got another sponsor. So
Melissa, it's like an auction.
Hey!
We're at like an auction. You go, girl.
Miriam, okay. We love
you. We'll send Melissa backstage here. Okay, so obviously you guys saw the first slide is me and Leslie on Groundhog's Day, which apparently Punxsutawney Phil, he did see a shadow. So like it's gonna be real cold. It's cold now.
It's so cold.
It's cold now.
So cold.
Yeah, sounds like the Rockies have no snow. The lizard people are probably controlling the weather. I mean, that's as far as I can tell. Something bad's happening.
Everyone cat called me yesterday and was like, I'm in a dark place. And I think this has a lot to do with it. I think so. Yeah, it's just all the lizard people.
I have a friend of mine was like, why haven't you looked at the Epstein files? And I was like, I don't have time for that. And she's like, do you not care about the thousands of women? And I was like, yes, I do. And so I am not looking away. And holy shit. Lizard people are running the world is all I have to say about that. And I'm very upset. So apologies for the multiple references I will probably make throughout this talk show to those things. Anyway, it's going to be a cold winter still. So, okay. Some more, I mean, I don't know. I guess we're also used to like awful things happening. So this didn't really hit a lot of people's radar, but ARPA-H had somewhat of a downsizing riff, whatever we're calling it these days on, I think Monday or Tuesday of this week. Looks like they did not lay off any of the program managers as far as any of our loyal fans have told us, but they did lay off some of the more supportive, I guess, parts of ARPA-H, like a division called Patio that I think did commercialization. I think they let go of some admin-oriented teams. So looks like it was a good chunk of people, maybe like a couple dozen or something, records or our loyal sources do not appear to know an exact number. We've gotten wildly different reports. So anyway, that happened. I do think that I think their director, Alicia Jackson, came a little bit later than some of the other agency heads. So this was probably something that was planned anyway, but still sucks for all of us.
Do we feel like we're getting closer to the end of surprise ones? Not that this was necessarily a surprise one, you know, at least.
I don't know, you know, like it's so hard because like the rumors swirl like amazing amounts. Like, you know, one of the things that I don't know if you remember at South by Southwest last year when we were speaking on that public health panel, Retesh's thing, and Lisa stood up and said ASTP or and ASTP is turning back to ONC and everybody's getting fired. Yeah. I mean, I should laugh because that's like a lot of people. But I think they've had some cuts, but like nothing close to what some of the other agencies have had. And I've heard a number of ASTPers say we're so valuable, like everybody sees why we're useful. It's not going to happen. And then I've heard other ASTPers say it's coming. And so like, I don't know, you know what? It's like, I guess we're going to see what the lizard people want. And like what happens, I don't know. But yeah, so I don't know. I do think that we'll see maybe a little bit more. I don't know. I don't think it's going to be quite as dramatic as it was in the beginning of the year, but what the hell do I know? Not much.
I don't know. Yeah, I don't know. Yeah,
we'll see what happens there. I did hear also that ARPA-H is aligning more on like the biotech side of things. So,
interesting.
Also got a report that they are still doing a lot of health tech things. You know, who knows? Who knows? I think it all just depends on what the market's like. So we'll see. We'll see. There were, you know, the other, I think we last week reported on some potentially fake news from a potentially fake site that looked a lot like the Health Tech Talk Show, but has no affiliation. Rumor site about how Oracle is going to cut out its health division in order to pay for its data center work. Also, you know, there was some drama with NVIDIA and OpenAI. That deal is not happening, and then there's this like anyway. This tweet was awesome, and then please check out the comments because like
it's so good.
While I'm dealing with lizard people, like this kind of shit, I'm just like, you know what? Like, yeah, you go Twitter, like.
Yeah, I mean, like even like the mainstream media headlines of this is. What happens when you lose $100 billion? Like that's like it's a good question. It's a good question for lizard people.
I know what would happen to me, but I guess if you're a lizard person, $100 million is like no big deal. I don't know.
Well, the Oracle thing's what 1.4 trillion, and I was like, I can't even count that high. Like I don't even know what that means. Like what is that? Like it's like all fake dollars at this point.
Yeah.
So
same. But yeah. I appreciate these people and their mega deals. That's great. God bless you. Yeah. So Bill Cassidy. So we all saw that Bill Cassidy made some compromises in the confirmation of Secretary Kennedy into that role. He had a lot of concerns. RFK told him like, no big deal. I got you. We'll do everything. We'll work together. And then as we saw, you know, in the hearings in the fall, Cassidy was unhappy with Kennedy's progress and what he's doing. That said, he still is responsible for getting in there. And now it looks like there's a massive effort to, hey, Jim, there's a massive effort to get him voted out. So despite the fact that he went all in, probably so he could stay in office, it looks like he's going to be facing a lot of headwinds. So you know what I think this guy should do? I think he should just be like, you know what? I've had a long, great career. I'm just going to go all in on doctoring and tell America through the end of my term what doctoring is like, what's real, and just go out with a flame. And you know what? Like he might even get voted back in for doing that.
He might. I mean, like I always wonder about this when it's coverage, because is that true? Is it true that people really hate him? Because if like mostly they just interviewed some guy on his staff. So like, did people really hate him because he questioned RFK Jr. during confirmation? Like, I don't know. Is that true? I don't know.
I don't know. Like, also, like, the only thing that matters here is the great people of Louisiana.
Right.
Like, do his constituents actually give a shit? Like, are they mad at him? I don't know. Like,
seems so like
I don't know. I guess we'll find out. I'm questioning everything these days, but I think he should just go for it. Like, just get out there, Bill Cassidy.
You should call him. You should call him.
I should call him. I should
call him and let him know.
Maybe I'll tweet at him and see what happens.
Yeah, oh my God, you should.
I'll be like, hey, I think you should just go for it. Like, just go out with a bang. Like, this might be your swan song. Like, just do it. Like, just go for it.
That'd be
anyway.
excellent.
Okay, so like, okay, Leslie, what do you think about this? Because I have opinions and I'm going to talk a lot.
No, I have well, I have a different thought on this, but so you tell yours first, because mine's more kind of veering into a different direction.
Okay. Yeah. I'm like not really on the business thread this Friday. Apologies in advance, loyal fans. Whatever. Okay. So I am very pro people giving a shit about women's health. That's great. Also, I'm like super delighted that everybody cares about menopause these days. Listen, as soon as the menopause comes for me, I'm going to like throw on a patch and keep going. Like I am here for this shit. I also feel like though, instead of everyone really studying women's health, all we're doing is monetizing menopause. Because now I feel like whenever someone says they have any affliction and you're a woman over 40, you all of a sudden it's just perimenopause and there's no need to research it anymore. So I'm like kind of pissed because I feel like this is just like, what are you talking about? Mini health is a unicorn. And I'm like, right, but like, what if, I don't know, I have uterine cancer? No, it's just menopause. Like, yeah. I don't know. I feel like it's just like the Band-Aid for all women's health is we're all in perimenopause and we're just fucked.
Yeah. And I don't know that that's this is a totally different tangible, but like, I don't know. Is that even reimbursable? Because it's not, like fibromyalgia is kind of a fake disease. It's not really everyone, but like it's kind of not considered. So a lot of times it's like a grab bag disease. It's a grab bag of symptoms. And so I wonder if that's the same thing. But the thing that I thought of when I saw this was actually from a few weeks ago after JPM, there was I think it was a Forbes article, and they were talking about how women's health has finally surpassed $100 billion in M&A. And it was talking about, I just thought it was interesting because they were talking about how no one has ever counted because no one classified things as women's health. And so investors would say, hey, well, I don't know if I want to invest in women's health yet. So now they went back retroactively. Now they invested in women's health. Yeah, they retroactively looked back instead of like an oncology company that only served women. They looked at it as a women's health company. So they went backwards and counted. And so overnight, essentially, they hit $100 billion in M&A, but in exits. But it was interesting because they were saying that now, not them, like now women's health. It's just so funny when you see a headline or when you see an article or something there. They're like, and now we're going to focus on women's health. And I wonder if it's because they have this catch-all now where they can just there's so many women in perimenopause because it can be,
all of us go through perimenopause.
32 to 55 or something, like, sure. Yeah, I get it.
Yeah. But I feel like that's the thing. Instead of anyone taking you seriously still as a woman, now you just you are monetized and they throw a patch on you or throw some cream on you or give you something to throw up your hoo-ha that's going to like, testosterone you up. And like, listen, I am here for that. Like, I'm here for women who want some testosterone, who like, apparently you feel like you've got tiger blood on that stuff. Like, I'm here for it. You go, girl. Yeah. But like, also maybe there's something actually wrong with you that's not related to your hormones. Like, I don't know.
So, okay. Can I say this? Okay. I don't want to go down this.
You can say whatever you want.
I was at a happy hour last night, everyone, with a friend, colleague, business person in healthcare. Anyway, he was talking about how his wife just went on whatever testosterone thinking, and they both thought it was going to be like the miracle drug, and he was like, yeah, it was real disappointing, nothing really has changed. I was like, well, it's possible something else is wrong. Like,
it's possible you have like an actual legitimate diagnosis that's not just midlife. And I don't know. Like I said, I'm here for it that like we care about menopause now, like yay, but like also
to be fair,
I don't know. There's I don't know. All right, moving on. We need to bring a special guest on, Miriam. I don't think we told you this. I think, hey, Miriam. Hey, girl. How's your audio?
Oh, unmute.
Got
Yay.
Me? Awesome. Yep. Yay. Great. Hi.
Hey, how you doing? Okay, so loyal fans. We love Miriam.
Yes.
Like, I feel like she's now both of our work mom.
Let's just don't go down that path. But hello. But as a mom,
you want to talk about menopause?
Let me just say, as a woman who's on the other side of menopause, nobody gave any shits about anything that women were going through when I was going through it. But I do think I put 100% in the chat because all this is a label, a banner that the investment community has come up with once they figured out a new thing to invest in and how to package it. It's very similar to MSK That didn't used to be a thing either.
Yeah.
Musculoskeletal, or some of the other labels we come up with. So I'm happy to see that progress for MIDI. I am a huge fan of Joy and Blokes. We can have another conference about that, or a call about that. But to get what I get from Joy, which is all cash, I would have had to gone to 5 different specialists. That's the brokenness of, quote, women's health. It's just, I'm a human. I happen to be a woman. Here's all the things that are wrong with me. Is there one person that I could talk to instead of 5 that would listen to me? So if I was not funding my own company, I'd put my extra capital into the sector. I think it's going to have strong returns.
Yeah.
Anyway.
Well, God bless America. Okay, so Miriam is our expert in all things like pharmacy, pharmaceuticals, manufacturers, PBM,
price affordability.
And so she's also the CEO of RX Utility. You guys have seen her before on the show. She's amazing. We brought her on here because we've got 3 slides, Miriam. I think we only told you we had 1, but there's 3. About 1, PBM reform, the Express Scripts lawsuit, and then finally, you're going to give us some deets on the Trump RX. So
breaking news. I'm happy to.
Congress came back. It appears they only closed the government for a little bit, and came back and we got some landmark PBM stuff going on. What can you tell our loyal fans about it?
Yeah, actually, I've done a couple of other interviews on PBM reform just this week, so I'm primed. So really, this is about getting rid of the shell game of pricing on fake prices that are called list prices, and then something called rebates and something called net prices. But to make it easy for me to understand, I think of it from the person. So most people in the U.S. get their health insurance through their employer. So that means, let's say I'm an employee of RX Utility, and RX Utility chooses a plan for me as the employer. So the employer chooses the plan for all the people, and in choosing that plan, part of the benefit that the employees are going to get is medical, and part of it's pharmacy. So what happened in the industry is they carved out the management of the pharmacy claims away from the medical claims, and basically created another department and said, pharmacy claims are different, let's do it differently. And then that became a whole set of companies and became a whole industry. The PBMs then sit in the middle between the manufacturers, who sell it to a PBM for a certain negotiated price with the employer. So Eliquis is a great example. List price for Eliquis is $600. It's a blood thinner for heart disease and stroke. It's one of the top 10 drugs in the world. List price is $600. The negotiated price between the manufacturer through the PBM to my employer is $600. But when Miriam picks it up at the pharmacy, I'll give you a $300 rebate. So here's what happens. Miriam pays $600 per bottle of Eliquis until I reach my deductible. But RX Utility, the employer, pays $300. And where does that $300 go? To the balance sheet of the employer. That's why you hear people talk about employers are hooked on the crack of the rebates. This is the game that we've been playing. So PBMs make it worse by saying, I'm going to pass through all the rebates to the employers, and this is one of the ways to keep your premiums down. But even that's not true, because they'll get a $300 rebate from the manufacturer, and they'll say, hey, employer, you can have $200 of the rebate. So now they've made money on what's called spread pricing, and there's just games all the way around. So it's an inflated list price that means nothing. So they can negotiate a good deal, give kickbacks to the employer, but make the human being pay 100% of list until deductibles are met. So it's just all a big sham. So PBM reform is getting rid of that by forcing the PBM to do 100% of the rebate pass through to the employer. And the greatest thing about it is that patients are going to pay on net price. So when I have to pay out of my pocket, I now pay $300. If my employer is going to only pay $300, you better damn well believe I should pay $300. And one of the reasons this connects to the labor, the DOL law, is because when you are a self-insured employer, and about half of all employers are self-insured, you have a fiduciary responsibility under the ERISA law to be a fiduciary for all your employees. You're the one who picked the plan. You're the one who knew you were getting the crack rebates on your balance sheet that nobody else knew you were getting, and you're not passing through the savings to the employee. So you're damaging the very people you're supposed to be helping from a fiduciary perspective. So that is a big win. The transparency is a big win. It is a big move. It's not, as we know, all laws are just, they start with the law, then they go to the regulation, then they go to the enforcement. You guys talk about that all the time. So, but this is a big step.
Yeah. So who makes less money? It sounds like the employers.
Well, the employers don't get the crack cocaine on the rebates necessarily if the rebates go away. But what this starts with the first, it doesn't say you can't do rebates. It just says, hey, PBM, you can't keep some of the rebate. You got to give it all to the employer. So in theory, the employer wins, the PBM loses. And if you look at some of the quarterly reports and some of the market guidance from, the big three PBMs have got ESI, which is owned by Cigna, which is, I think that suit was with the ESI. And then you've got Caremark, and then you've got Optum. Those are the big three. They're all owned by insurance companies.
Yeah. Okay.
So it's hard to say who the clear winner is until you see the regulation and the enforcement behind it. But it is good that we are moving towards a net price ecosystem. That's a very positive thing for our industry.
Okay.
As a whole.
We are not mad.
No, we are not mad. We are not mad.
We are not mad, America.
We are not mad. It's a good thing. It's a good thing.
I can't fathom how much these guys were paying lobbyists to prevent this from happening. But also, we all kind of knew this was maybe going to happen, right? Like, this is not a new topic.
It's been around for a long time, but I think it was Cigna that reported a $500 to $600 million hit to earnings based on what they think they're going to be losing in this pricing game. So listen, people are picking up money left and right through this thing. Mm-hmm. So when we start seeing it regulated, and I think their stock took a 20-25% hit the other day. So this is material because they have relied on these cash flow streams that show up on their balance sheets. So that's why I said it'll be a little bit harder. You have to let it settle to see who really, really wins and loses.
Yeah. Well, their big drop, the 25% drop across the board, was also from the advance notice, right? For Medicare Advantage. Yeah.
So you had Medicare Advantage, you had the DOL thing happening, and then you've got PBM reform kind of all happening at the same time. And people are like, holy cow, we have to stop cheating. So we stop go down.
Weird. Hear that, lizard people? I don't know. Anyway, the other thing, so related, this was a big settlement. I think this has been going on for a while. Express Scripts, PBM stuff. Miriam, do you know anything about this? Because we didn't read it.
I do. It is the same thing that we just talked about. It is that for this, ESI was the middleman here, taking advantage of spread pricing and taking what I call the rebates kind of a kickback, but creating an artificially inflated list price, then negotiating on contracts that no one is allowed to see or read, a way to buy their way up the formulary. If you're looking at it between the manufacturer and the employer that you want covered on that benefit design. And then I'm buying my way up the list like a Google ad based on the kickback that I'm going to give you. And what that ends up doing is inflating all of these prices because you're starting with an artificial number that's high. And so it's just raising everybody's cost. And those are some of the things that they took exception to, filed this lawsuit. And the FTC won. And many of the things that it is going to call for is the same thing we just talked about. Patients paying off of net, as an example.
Yeah.
So they're really good directional things in terms of transparency and pricing. Stop with the shell games and the kickbacks. Let the patients pay on as best of an even playing field as we can.
Awesome. Okay. We're also not mad about this. Are we mad about this?
Well, I had to put it on today because this, as everyone knows, the Health Tech Talk Show is where all breaking news happens. Okay?
That's what I'm talking about.
And this just happened last night. So I had to talk about it. So let me tell you guys what it really, really is. This is a price directory. Okay. This is not really a new set of prices. Okay. There are only 40 drugs. Some people say 43, but let's just call it 40-ish that are on here right now. And there are two things that it does for the consumer, so which we think are good because we think price visibility is good, right, for consumers. We're trying to get rid of confusion and opacity. So the first thing is that it surfaces, it all started around the GLPs. And you remember last year, the first time ever, pharmaceutical manufacturers started selling directly to consumers through their websites. That had never happened before. Okay. So that was already putting tremendous price pressure on the GLPs, bringing the fake list price of $1,300 down. Remember, you saw it fall to $499, then it was $399, now it's $149. That was already happening from what the power of consumerism and so forth. But you had Trump's MFN, most favored nation pricing efforts come in, and those things coincided. They're not causal, but they coincided. On this website, it just surfaces those prices. So if you were to search for Wegovy, you would see, or Zepbound, the 2GLP, you would see that. Then there's a link that directs you to the manufacturer's site, and that's where you buy the drug. So it's just, in that way, it's like a directory, like a list. The other thing that it does is it provides coupons. And so this website is intended for people that are paying with cash. Okay, think about that. So it's very much like the direct to consumer from manufacturers, which that's a cash price. So people paying with cash for their medicine is now at about 11% of all prescriptions filled are paid by cash. So that's not a lot, but it's growing very, very quickly. And we're seeing these things change in the world of high deductibles. In my Eliquis example earlier, guys, I have a $10,000 deductible. That's a hell of a lot of Eliquis to buy before I'm even able to use my insurance benefit.
Right.
Okay. So think of it as a new source of pricing data for medications, but just for a limited set. It's very similar to our announcement, Arch Utilities announcement with Buzz Health earlier this week, where Buzz has its own website for drug pricing. So we aggregated all the Buzz prices. We will end up aggregating these Trump prices into our Arch Utility best price calculator because it's just another source of pricing. Now, because I know you guys are such inside baseball freaks and nerds like me, you do get coupons that you can use at the pharmacy counter for drugs that are not direct to consumer from the manufacturer. And it looks like a coupon, except of course it has like a gold eagle on it or something.
I love that.
We're in, a boudoir in Versailles, but you can take that to the counter and use it. But how does that work? We have all this now. GoodRx did a press release last night that they're the integration partner under Trump RX. If you know what you're looking for with pharmacy adjudication, this is the nerdiest of the nerds, you would know what a BEN-PCN combination is. But there's a set of questions around the nerdness of our industry in the NCPDP world about, well, what rails are these running on? Who's the PBM on the back end of these things, right? Well, the manufacturer coupons, they're different But these cash coupons, they're new. We're basically writing the infrastructure of GoodRx so that you can use them at the pharmacy. But the last thing I want to share with you is, so there's more to come. There's a lot more to come about kind of the inside baseball. One of my biggest questions is, when the cash coupons are used, are the pharmacies charged an admin fee like they are with all the other cash cards?
Yeah.
A consumer uses GoodRx at the pharmacy counter. That pharmacy pays GoodRx $6 to $8 per script just to get that patient to the counter. It's like a marketing fee, like a customer acquisition cost. So pharmacies don't like that, right? Of course, because it's money out of their pocket. But that's how all the kind of the cash cards work. So there's more to come about that sort of those business economics. But from the consumer's point of view, I think this is also positive. So I can't believe that I have 3 positive things to say on a Friday, but 3 positive steps forward from the ledge-reg, kind of side of the world. This, because this focuses on making prices more available for consumers, and anything that does that is good. It just adds 2 cautions. One is it makes it a little more complicated, like what site do I go to? And then the other thing is they're not necessarily the lowest price on all of these. So more to come, where somebody might automatically assume. And then the last thing would be, is it better for you as a human, Leslie or Kat, to use your insurance or to pay cash? And people need help understanding that. So, we're committed to helping consumers find the very best price for them for that drug on that day. And so this is an input to that larger effort, which is a net good. It just isn't really anything new. It's a website that directs you to other places. So
it's, Kat says the second mouse gets the cheese a lot. And it's, so like, it's cool that they're doing this, because I think there's a lot of people out there that don't even, I think there's a lot of people out there that don't even know that there are other prices. So in some ways, this is like a national campaign to let people know that. But to your point, hopefully it won't confuse them to the point where they don't realize that maybe someone will come out with something a little bit better that's more comprehensive.
We'll see. I'm looking forward to seeing who's making more money here, because this is America. So someone's making more money.
No, you're right. You're right. So more to come on that. I'm doing a deep dive with NCPDP on this we're going to do a little webinar, Rick Sage and I. So there's more to come. But Kat, that's exactly right. That's what I meant about kind of this little bit of the missing pieces of the economics behind here. I don't want any money that gets made to go to some crypto coin that I've never heard of, like in reinvesting in something else.
The lizard people.
Yeah, the lizard people. I don't want that. So, but yeah, I would say net positive, because what Leslie just said, this is a spotlight from the most powerful spotlight beacon there is, right? To shine a light on something. So, I'm
awesome.
thrilled.
Happy Friday.
Thank you for coming on and telling us all these things. We appreciate it. Thank you for being our
pleasure.
social correspondent on all things pharmacy.
Thanks for letting me jump on.
Yeah, absolutely. Happy Friday. We got to buzz through the rest of this real quick. And then we got to get to our special guest real fast. So anyway, hey, check this out. This was Mario Aguilar, who was our guest on a show a couple weeks ago from Stat News. He wrote this piece about the Utah Doctronic program. This is the only statewide state thing that does prescription chronic disease refills for prescriptions that are approved. So he has a deep dive here. It's super interesting. Check it out. Also, more information about scribes. So I will say this, Brendan Keeler wrote this super nerdy, detail-oriented thing about scribes and how Epic coming out with their own scribe is not going to destroy the scribe market. I will tell you, sir, yes, it is. Because in the hospital market, there's always there's other markets for these things, right? There's physician practices, there's SNFs, there's all kinds of different things where these things could be used. However, typically when the system of record makes it easier to use their own internal solution, typically that's what the customer will do, because the best product does not win, the easiest product wins. Ta-da! And in some markets, the cheapest. So,
and if or okay.
Oh, I thought this was a very thoughtful article. It's just like not how consumers in healthcare.
But props to the AI images, guys. Props.
Yeah, no,
So
Brendan is super smart and his AI game is strong.
Yeah.
Other quick things here. There's been some pressure, which you see in the next slide here. The administration is not at all encouraging and certainly deterring any medical facilities from providing transgender care to minors. And then the Plastic Surgeon Association, whatever they're called, came out and said, yeah, don't do it till they're 19. And described various potential long-term harms. Obviously, there's a lot of controversy here, but interesting. This is a large group that does these things, and now they're saying that we should not be doing them. So at least until someone's an adult. Interesting stuff there. Last bit here. Leslie and I are going to DC next week for the ASTP annual meeting. We're throwing some parties, and Lisa is coming in too. She's flying in from India. We're not exactly sure when she lands, but
she flies straight from India to DC.
Yes.
Maniac.
I used to travel way more than that girl. I don't know when she goes home. So she definitely wins. Also, we're going to be at Vive. Last pitch here. Melissa says we've got like a couple slots. So Miriam just took one of our slots on this show. So call Melissa, not Kat, if you would like to be on our Vive live shows. All right. Now we got like our special guest. Did we, is your PR team like, oh shit, like what did you get up?
No, I'm going to leave now.
Fill the space. It's no problem. Well, Leslie, introduce our doctor.
No, I think you should introduce yourself. So I think this is important.
Are you worried you're going to say his name wrong?
Yes, it's really hard.
It's hard to pronounce.
I say that to guests when I'm like, oh, introduce yourself. Because I'm like, maybe.
I wonder if there's any, this is really important. I wonder if there's any conspiracies, because you know how they say serial killers or assassins or something, they always have 3 names. I wonder if you have 2 first names as your name. I wonder if there's like a conspiracy theory out there about that. Just saying.
Are you calling me a killer? Is that what's just happened?
No, you have 3 names to do that one. That's a very specific
Absolutely
one.
Not.
This is why I can't introduce you.
Are you a lizard person?
Why you don't want me introducing you. Are you a lizard person? What?
No.
Oh, okay.
Some academics are lizard people. Anyway, introduce yourself, Dr. Stephen Patrick.
Hey, so I'm Stephen Patrick. I'm a neonatologist and I chair the Department of Health Policy and Management at the Rollins School of Public Health at Emory.
I could have done that.
That's pretty legit. Okay. So Stephen, I met you at Academy Health's annual research meeting last year. And then it turns out we knew all these mutual people, and you're a neonatologist, and you were also doing research on baby using opioids. And in the lobby of the Hilton, I begged you to come to West Virginia with me and Leslie that next weekend to go to a fundraiser at Marshall University for Project Hope. And you actually said yes. And you came with us and you smashed into our, actually it was a large vehicle, but it felt small. And like spent the weekend with us in Huntington, West Virginia. Tell us why, and tell us why that's interesting for your work, and like just like I don't know, tell our loyal fans what's going on.
Yeah, I think it only felt small because of Darshak's music choices. But
and he's
just kidding.
I hope he's listening. He sometimes does.
No, I hope so. That's why
he is like not a great driver.
He just drives really slow. Everyone.
I wasn't going to go that far.
I mean. I don't know. I think his problem is like he drives in Boston, right? Where like you go like 10 miles an hour and it's fast.
Yeah.
And then all of a sudden there's like an open road and he was like, anyway, keep going.
Let's talk about opioids then. So let me just how about that transition for you? So I am from the great state of West Virginia. And almost all of our team's research is focused on the effect the opioid crisis has had in pregnancy and early childhood. At my previous institution, Vanderbilt, I ran a treatment program called Firefly, which is for pregnant women with opioid use disorder and their infants. It was a CMMI model. And so that's where our team does work, both, had done in clinical delivery and do work or everything from barriers to access to treatment to variations in care to now a lot of work focused on the U.S. child welfare system.
Like that's a lot. What is your biggest priority right now?
A lot of our focus right now is focused on the child welfare system. And
Okay.
as you all were talking earlier about all of how women's health, how healthcare in general is just completely siloed, all the incentives are misaligned. That is so true when it comes to both like human services and health in so many sectors, and that really plays out here. So a lot of our work is focusing on how federal policy is translated down to states for substance-exposed infants. Infants are the fastest growing group in the U.S. child welfare system today, mainly because of parental substance use. So that's where a lot of our focus is.
So this problem has not improved.
Oh, that's a hard one to know. I would say the problem is still very present. I mean, the question is having reliable data. We know that overdose deaths have declined. They've declined to the level of about 2020, though. They're still at a pretty high level. And when we were in Marshall, a lot of folks told us that one of the things they were worried about in Huntington was that there was less evident there because a lot of people had died. So I think it's complicated. Is it better in terms of the opioid crisis? It's still present. Let's put it that way.
Okay, so that's your focus. Like, what are you doing? Like an initiative, or what is it you?
What are you doing?
Yeah, what are you up to?
What do I do? It's a great question.
What do you do?
So we have what do I do? So that's some of our we have NIH funding we have a grant that we're partway through where we're doing this work. We also have some work focused on creating quality measures for opioid exposed infants that hospitals can use. So that's where a lot of that work is focused. Outside of that, here we do a lot of child focused work, particularly nationally representative surveys, other things like that to understand things, everything from screen time, mental health in kids, to food security.
Okay, so what are you're probably just going to say money. What are your barriers? Because I mean, nobody wants to be the one that stands in the way from helping babies, right? And baby deaths. Like that's that's a pretty easy marketable position. So what are the barriers that you're dealing with to move it forward?
Well, I would say that's true. No one wants to be that person, but the budgets don't follow that intention, right? I mean, you can look at any sort of budget evaluation for depending on the year. We spend more on maintaining the interest payments for the national debt than we do on children. So, I
what
think
a stat!
That's a good line.
I'm dropping some stats. I think the problem with the opioid crisis, particularly as it relates to this population, is we know what to do. It's a problem, I think, in maternal child health. I actually think there's enough money in the system. It's around incentives, fragmentation, and no one wants to own the problem all the way through the continuum, whether that is Medicaid, MCOs, to whomever. And ironically, in this space, it's Medicaid that really has the money, and Medicaid doesn't have much money.
Wow. Yeah, I know it. And this is maybe semi-related, but I know like children's hospitals and like pediatric anything, right? Even in health tech, like I think it's like the lowest investment bracket. Like no one invests in pediatric anything. But you think there's money?
Well, the problem is this. I mean, almost everything is relatively rare compared to adults. You think about what the market is. Here's a case example. So I practice newborn ICU medicine. One of the things we do when babies are very, very sick is put them on heart-lung bypass. So they literally have cannulas going into their neck. All their blood goes out, circulates, artificial heart and lung back into the baby. A couple years ago, there was one manufacturer that created one of those types of cannulas. It was short in the US, so the entire country changed the way they do to a more invasive type of this heart-lung bypass because it's relatively rare. There was only one manufacturer of that specific type of plastic cannula.
Wow.
So it's a big problem throughout all of pediatrics for things that we consider pretty common for children to things that are pretty rare.
Wow. Okay. That's like pretty rough. Okay. So tell me this, because I want to ask like how you got into this stuff, but we got a lot of like people out there, our 100 million loyal fans. They're all out there.
There you go.
What's like one thing that any of our loyal fans can do to make this situation better? Like tweet, donate money, like what can they do?
I think it depends on the problem we're talking about, right? I think the problem that we're talking about, I honestly think, like, if we're talking about the opioid crisis, I think we approach this the way we've approached so many problems in the past. The Ryan White Act is a great example about how we've sort of deployed treatment in a structured way for a big problem. We just haven't done that with the opioid crisis yet. From my perspective, like, just getting the medications out to people, we know that those medications help. They save lives. They probably reduce foster care placement. They improve birth outcomes. So there's that one thing. I think the general thing that we could all do is, in what area are we controlling? If you are an employer, for example, and we're just talking about the employer's responsibility for their populations, what are you doing to invest in the overall well-being of your populations? I don't think we're going to see a whole lot of federal action right now. I think states and employers in particular, I think there's ROI for this. The other problem in the space is that ROI is pretty far off.
Yeah, yeah. You're getting a few like audience high fives here first. Matthew Holt is mad that we're dissing Jarshek. We're not. We love that guy. Also, we got some of these, I think, are more just like FYI situations here. We got our bestie Jim working with UAB. I assume you guys all hang out.
Say that again?
You guys at UAB, like, you hang out with all the other universities. Like, you guys chill.
Oh, we just hang out. There's like a university club. There's like tweed jackets and their pipes. So we just all hang out. I'm not familiar, but I do think there's a lot of interest in, like, there are things that we do. Placental pathology is a thing where we look at kind of trying to understand. So yes, there's a lot of people in the space doing important work, including at UAB.
Yeah. All right, Helen, you got more. I think this might be Erica. She always shows up as just LinkedIn user. We got some others too. But, I mean, it sounds like we all might agree with this. Lots going on. Yep. Then we got Matthew Holt's back.
Yeah. So let's talk about infant mortality. That's a good one to really bring up the mood of the room.
Yeah.
Right?
Let's just,
so, mortality is like this overall, right? It's sort of high at the beginning of life, and then it goes, over here. About 25,000 infants die a year. It is not equally distributed across the United States. We talk a lot about maternal deaths right now too, which is good. One of the things that I would like to push for is for us to talk about them, both maternal deaths and infant deaths, in the same conversation, because the same disparities play through. Just to put some scope and scale, there's around 900 maternal deaths a year. There are around 25,000 infant deaths a year. And so I think it's important we talk about both, because when we treat moms and babies together and we think about how we have healthy moms and babies, turns out if moms are healthy, they tend to have healthier babies. And I think Matthew is right. I mean, we are higher than other OECD countries in terms of our infant mortality rates.
Yeah. Go ahead, Leslie.
No, I had a dumb question, I think. Because, like, so in Georgia, where we all live, the three of us, one of the number one public health initiatives, right, is to lower the maternal morbidity numbers, because ours are really bad. Like, why wouldn't it be the exponential deaths of the babies, right? Is this a dumb question?
Is it a dumb
No, I don't think it.
Is it a dumb question?
I don't think it's a dumb question.
Because no one wants to own that issue? Is that it? No one wants to...
I honestly don't know. I actually think, for the most part, we've not actually done a good job of talking about maternal morbidity and mortality either. And so this is why I think we should be talking about both, because they both affect each other, right? And it turns out too, we know in this space around opioids, for example, which is a leading cause of maternal mortality in many states for deaths after delivery, Georgia, Tennessee being some of them, Ohio. When moms lose custody or have relapses after delivery, that also increases their risk of mortality. So I think part of it, to this point, we need to be focused on moms and babies as a unit.
Yeah. Totally agree. Awesome. I don't know. We should look into that. I do assume that a lot of that too is just like who's lobbying, right? Like, I don't know if the American Academy of Pediatrics is out there spending all their money trying to get like Medicaid initiatives, but I bet there are, well, I don't know. I mean, no one cares about women either. So it's hard to know. But okay. So like,
I care about you guys.
Thank you.
Aww,
Thank you.
Aww.
You know what's great? We have you and we also have each other. And you know, what we always say is like, you know, the world may have let us down, but you know it never has? Business. It's the best relationship I've ever had. Anyway, sorry, Dirtbag. Love you too. But, no, listen. Okay, so back to like tangible land. So, you know, you talked about a lot of like surveys, and you're doing all this stuff to try to like show what's working and what's not. Is there a state or even a region that you think is doing programs really well to, you know, child welfare, maternal mortality, anything like that? Like, what, like where can we point to be like that's working? If anywhere.
Yeah, I don't think we've got it down. I mean,
yeah.
I think that's what's problematic. And when this plays out, if we just again we'll talk about infants in foster care. In my home state of West Virginia, we're talking like 1 in 25 infants are in foster care. It's an
Yeah.
extraordinary
Oh my gosh,
amount,
yeah.
and these areas are chronically underinvested. Like in West Virginia, about a third of child welfare positions, staff positions, are just chronically open. This gets a little bit at how we're investing in the systems, and one of the things we're talking about why things don't work out the way we want in maternal child health. This is true for moms and babies. It's a mix of entitlements and block grants that are really complicated, some that are administered at the state level, local level, and there's this scarcity problem in many of these programs where we sort of get sometimes duplication, sometimes overlap, sometimes people just fall through the cracks. And so in a sense, this is where some of the holistic approaches need to be. And I would argue in this population, the human services aspects matters as much as the health services. So one of the things, if you really want to help women in recovery, get the medication for one, childcare. Childcare may be the most cost-effective thing we could do for women in recovery. Yeah, there you go. I should just say childcare.
Yeah, that's what I should say. And then
yeah.
Yeah. So that's interesting stuff too, because a lot of times I think people decouple that from like the medical system. Childcare matters because you can't get treatment if your kids are like, you don't have anywhere to put your kids.
Yeah.
Yeah.
I feel like I see a Zoria and Miriam campaign.
Oh yeah. Zoria Foundation. We accept donations all the time. So okay, what's Erica saying here? Oh, this is the long one. Hold on. Is there a question here, or is she just schooling us? Probably. Oh, Erica, this comment is so long it doesn't even, we can't even get it all.
Child less than 32.
There's a budget.
Wait, is she fact checking me saying I'm right or I'm wrong?
It's unclear because the comment, it's too long, it won't show up. She'll tell us again later. We'll figure it out. Okay. But yeah, okay. So like, we don't have, like, there's no good model.
There are good models where we see investment in kids.
Okay.
In other countries, I would also argue.
Other countries.
We did something remarkable in the U.S. Well, we also did something remarkable in the U.S. with the child tax credit. We know that the refundable tax credit for the 6 months it was in place took child poverty to the lowest levels they've been in a long time. And I think there's a lot of concern that people use those dollars to do things that maybe they shouldn't have, but that's actually not true for most of the analysis of that. So part of this is just making parenting a little bit easier. Parenting in 2026 is really hard. And when we sort of distill down some of these numbers, we released data last year about food insecurity in Georgia. A third of Georgia kids are food insecure. Yeah. There are things we can do about that in local communities. There's policies we can pass. Universal meals in schools is one of those. Most 90% of Georgia parents support it. It's pretty bipartisan. So I think there are areas, if we had a focused child agenda, we could get to. And I would just highlight that, I worked for a bit at the White House Office of National Drug Control Policy. Every year, if things are working right, we have a national drug control strategy. We don't have a national strategy for kids. And I think what happens is they're afterthoughts, or we see like we saw in COVID, where we're shutting down schools and keeping kids out of schools, but the bars are open. So we consistently are not really putting kids first.
Yeah, that's wild. And going back to the universal meals in school, I know that was like, there were actually like awesome outcomes with that when we had it during COVID, right? And then it was like, it's going away.
Yeah. Yeah, I mean, that's a great point. So during COVID, we made meals free in school. We had places for kids to get meals in summers too. That's a place where kids are more food insecure. And so, Yeah, and we know the price of food has been expensive. In some of our work, when we contact parents, we talk to them about have they changed their food spending habits because of costs. Yeah, they are.
Yeah. Yeah. Wild. What else? What other like policy changes can happen to make things better?
I would say part of what we need is a focused policy agenda for kids
Just
that
like we need a
crosses.
plan.
You just need it.
Yeah, we have to have a strategy, right? I
Yeah.
mean, we don't really have a strategy when it comes to like what are the top issues facing kids today, and what's our strategy for them, right? So I think when we ask parents, we just released this actually earlier this week. What are your top concerns? This year, the rose to the top is firearms, gun violence is their top concern for kids in Georgia. Then education and school quality, and social media and mental health. That's what we're hearing. We also know what the top causes of death for kids are. Firearms are the
Right.
leading cause of death. We should be talking about this. What are we doing about it? How can we prioritize what we're doing for kids?
The firearm thing is so interesting. I know we're close out of time, but I know that in a lot of data, I guess, or a lot of like these studies, like
Yep.
firearms are just excluded, even though if you put it into the data again, it's like number one cause. Like, why is that? I mean, I can guess why that is, but is it why?
I don't know. I mean,
Because of lizard
Is
people.
it, I think because of lizard people.
but I find that across the aisle, and especially even among firearm owners, most people agree on the things that we should do. And for kids, the most important thing we could do is safe storage. So
Yeah.
if we just keep guns safely stored away from where kids could get a gun, that's important for toddlers. It's important for adolescents too. And as parents, when we send our kids over to someone's house, we should have that awkward conversation. Do you have a firearm in your house? Is it safely stored? In Georgia, half of parents are firearm owners.
I think it just like I don't even know how to talk about this conversation because why isn't it why isn't there a policy? I just get confused. Like why?
Because of lobbyists.
Yeah, I know.
Yeah, Darshan, so I grew up around guns, and I am
Yeah.
pro Second Amendment over here. Darshak and I get in a lot of fights because he's like not the same person as me. His big thing is like remove the liability shield from gun manufacturers. He thinks that would solve a lot of problems, but yeah.
I honestly think if we just all came together and agreed on the problem, we can work through a uniquely American solution towards it. I think we should all just, like, the data are what they are. So leading cause of death in kids, what can we do about it? What we find when we talk to parents across party lines, most of them agree on most things, including both incentives and penalties around safe storage.
Yeah. No, I agree with that. Good point. I think that's true of a lot of things. If we could all just get together and actually talk about the problem.
Yeah. No kidding.
Let's just agree that kids shouldn't die from guns.
Yeah.
Agreed.
Again, this should be the uniting topic. Like the one thing that we can all agree on is that no one wants babies to die and kids to die. Like I feel like this should be the unifying topic. But here we go.
Yeah. Except for the lizard people. That's
well, they're
anyway,
there
whatever.
aren't that many of those.
But I don't think that there are. That's true. Okay.
Yeah,
All right. Dr. Stephen Patrick, what would you like to tell our adoring fans before we end our segment for this week?
Well, first off, it's a pleasure to be here. I do think part of this is like, think about kids in your orbit, what you can do, not just for your own kids, but treating kids down the street as if they are all of our kids, because that piece is important as we sort of work through what our future might be and creating making the U.S. the greatest place where kids can grow up and thrive.
Yeah, grow up and thrive, because then they got to take over. So it'd be good if they were,
That's right.
Healthy, happy, and whole.
Yeah.
And we need to set good examples for them in the way we treat people and the way we talk to.
That's right. All right. Well, Stephen, thank you for coming on our show. Thank you for tolerating this. Miriam, special guest, thank you for explaining the world of PBMs and pharmacy regulation and all that to us.
Thanks so much for letting me join.
Yeah, we will talk to you guys later.
Happy Friday, everybody.
We'll see you. Happy Friday.
Bye.
Maybe.